All right, welcome to Webinar Wednesdays, everybody. Thank you so much for coming. I'm Carly Andrews. I'm the Outreach Coordinator for the North Dakota Brain Injury Network. We try to do these every other Wednesday from 1:30 to 3. There will be a link on our website to view the recording later if you want to watch again or anything like that, or want to share with anybody else. And then there's also a CEU request that will be there for you as well. And just gave you about a day to get that. That should be up by the end of the day tomorrow, I would think. We do have Webinar Wednesdays scheduled for January and February. The formal, sorry, I keep getting a lot of people. This is a good problem to have. People are waiting in the waiting room. Yeah, so we have January 13th is community participation. Jessica Kersey's an OT with the University of Pittsburgh, and she's going to come and talk about kind of participating in community after a TBI. So that'll be a really good one. And then we have Love Your Brain coming January 27th. February 10th, Post-Acute Medical down in Fargo is going to come, and they're going to give us kind of a virtual tour of their space that they have. Yeah. And on February 24th, we're going to have Alla Lisk. She's a functional neurologist in the Fargo area on. Again, we've had her before. And so, yeah, I am going to turn it over to Dr. Biberdorf now and let him take it away. If you have any questions, feel free to type in the chat or raise your hand or just unmute yourself and ask, and we'll just stop there, but I will let him take it away. Thanks.
Thanks again, Carly. Yeah. Well, it may be an hour, it may not be an hour, but we're going to open this up to a lot of questions. If you want to ask questions, go ahead and holler, but hopefully we can go through this. I've kind of amended a previous talk to concentrate more on the cognitive and attentional issues that are involved with vision as a result of TBI. And so we'll kind of emphasize that and kind of slide through some of the other stuff. But if at the end of this lecture, I'm going to send to Carly a PDF of the lecture. And if you want a copy of that, she can maybe forward that to you so that you don't have to worry about taking all kinds of notes. So here we go. Basically, this is my first slide, of course, all my affiliations. You can read on that if you want. Here's I call it my disclaimers and disclosures. And these are the companies that I do some consulting with. And you guys are pretty much, I'm guessing, familiar with the categories of head injury as with the Glasgow scale. I'm going to skip that, but we're going to start with this slide. And the question is always why is vision such an important thing with TBI? And the biggest reason is that so much information comes to the brain through the visual system, and that the visual system, the brain has such an extensive network of neurons that traverse the brain that's involved with visual processing, and that's over 50% of it. And that the brain itself consumes, the visual system itself consumes so much energy just through visual processing alone. It's estimated about 45% of the brain's energy is consumed by that visual system. And then the latest research is showing that, about 90%, it's almost ubiquitous if you have a concussion, that you're going to have one or more ocular problems as a result of the concussion. So, and then the hidden vision problems that tend to persist months after concussion are extensive. And so the biggest reason I think we're beginning to realize is that these vision problems can severely undermine the efficacy of other treatments, whether it be posture and balance and cognitive processing and general workplace productivity, that to ignore the visual system is beginning to be known as kind of a mistake. The biggest thing I try to explain to people about head injury and vision is that there's two main categories that we have to look at. One is the visual impairment, which is more of a severe or focal problem with the visual system. Maybe it's an eye muscle that absolutely will not move because of a cranial nerve palsy, or it could be under visual impairment, a visual field deficit that occurs because of a stroke or head injury. These problems tend to be more permanent, and patients are generally aware of them. But what tends to be more prominent, especially in mild traumatic brain injury, is what's called a visual dysfunction. And that's a disorder of the afferent system, incoming information or outgoing information, the efferent function. And like I said, it tends to be typical of a mild TBI, and it can have an oculomotor origin, meaning eye movement, coordination of the eyes, their eye teaming, tracking, fixations, the focusing mechanism, or it could be a non-oculomotor, meaning visual spatial awareness and perceptual or perceptual motor integration functions. And those tend to be more predominant. These symptoms are also highly correlated with visual dysfunctions, and a patient many times is not even aware that they are not functioning like they used to. They may blame it on, they may blame some of their fatigue, for instance, on cognitive problems when actually it may have an oculomotor basis. So, and that can then affect schoolwork or reading and employment, things of that. The nice thing about a visual dysfunction as opposed to visual impairment is many times visual dysfunctions don't have to be dysfunctions. They can be improved through vision rehabilitation. We'll get into that a little bit. So just kind of an overview of the difference between an impairment and a dysfunction. Many times in TBI, where it's an impairment of the visual field or field loss. And this is just kind of a slide showing a pre-chiasmal, meaning in front of the optic chiasm where there's an impairment, or post-chiasmal. These are the field losses that you will generally see. I'm just kind of going through it quickly. And of course, when you're talking about a visual impairment, that tends to be more permanent. It is handled mostly with prisms and magnifiers and telescopes and large fonts. And although there can be some training involved with scanning strategies and things of that nature, but many times the vision specialists at the North Dakota Vision Services or School for the Blind, they are kind of at the forefront of helping people with these visual impairments. When we think of visual dysfunction, again, I mentioned mild TBI or concussion is very common with these dysfunctions. There's 2.5 million ER visits in the US due to head injury, but 80 and 90% of them, thankfully, are mild, but unfortunately, these mild ones are many times never seen medically afterwards. And it's been estimated that about 15% of these mild TBIs are symptomatic over a year. And again, I'm not going to get into the neurology involved. We're kind of all familiar with some of these post-TBA pathophysiologies, these neurological issues that occur because of a mild TBI. I'm not going to go into that in detail, but I will say this, that over the last 10 years, let's say, there are two big organizations that are looking more and more into the visual sequelae of mild TBI. And those two entities are the University of Pittsburgh Medical Center has added the vision ocular system into its whole concussion trajectory protocols. And it was one of the first in the United States to add vision and ocular dysfunctions as part of its trajectory. The other group is the Veterans Administration. They have placed a big emphasis on the visual ocular aspects of head injury and concussion. So it is beginning to become more of a prominent aspect of many organizations. What I like this slide because it can show the overlap of all the visual, all the various disciplines and where they overlap. And if we look at, and today's topic, of course, is mostly cognition, attention, and vision. If we look at the colors up here and we look at some of the areas that they overlap, we see a high correlation with cognition and vision in terms of headache, fatigue, confusion, brain fog, trouble reading, social isolation, and trouble speaking of all things. So there are some overlaps here that, and again, correlation does not mean causation, but I'm hoping as we talk about these things that you're going to start understanding how oculomotor and non-oculomotor problems as a result of a head injury can then have an indirect, if not a direct, impact on cognition and attention. What are the typical things that we are finding with head injury and the visual system? The first thing that we think is interesting is that instead of your eyes lining up straight, there has been a tendency or a noted tendency in patients who have had a head injury, mild or moderate or severe, for the eyes to go out. So there's a tendency to an exophoric or an exotropic drift, meaning that they now have to put energy into keeping their eyes lined up. In addition to this, there's a very interesting thing called a fusional vergence dysfunction, where the person can get images single, but they can't hold it. There's a tendency for the eyes to either drift out or a difficulty keeping it single. And this is particularly true up close where they're doing close work. And that results in a problem called convergence insufficiency, where the eyes have a real tough time maintaining a converged vergence maintenance while doing close work. Eye tracking difficulties, we're familiar with saccadic eye movements, which are the quick eye movements, and pursuits, which are the slow eye movements, following eye movements. Those are often disrupted after a head injury. Blurred vision, which has primarily to do with the focusing mechanism, especially in patients under 40, where their little focusing mechanism is impaired. As a result of all of these things, it can lead to visual discomfort and eye strain. But the two big ones that are seen are receptive problems in light sensitivity and in motion sensitivity. They're very, very prevalent. And I'm going to try to explain some of the theories behind what could be causing these light and motion sensitivity difficulties. And then this can lead then to concentration difficulties, because these visual problems, either in the coordination of the eye movements or the sensory overload, can reduce concentration, contribute to reading problems, depth perception judgments, and even allocation of one's spatial awareness, where they feel they are in relation to their world or their sense of midline. So I like this model because it is probably the best way to think about things in a clinical sense, how to approach somebody with a head injury and suspected vision problems. And this was put together by Dr. Ken Cuffredo out of New York. And it's a 4-tiered model, and I love it because it kind of better explains and helps guide optometrists and non-optometrists in what to do for these patients with head injuries. The first thing, of course, is a basic vision exam, and that can be done by any general optometrist, ophthalmologist. And the basic visual exam is followed by a more intense analysis of the eye movement functions, how the eyes team, how they track and focus. And that's followed by an assessment more of the receptive problems in the visual, spatial, motion processing, and light sensitivity issues, which is then followed at the top of the pyramid by the other things that could be correlated with these vision problems that are dominated by other professions like speech language pathologists, occupational therapy, PT, neurology, and psychology. So this is kind of my framework, which I enjoy using, and I'm going to go through it a little bit in detail, and then we're going to try to put together how cognitive and attentional problems might fit into this model. Of course, your basic vision exam is what's your best acuity, are you farsighted, nearsighted, need to have astigmatism, and what's your eye health like, okay? And again, these scales that are used for this are what we call a graded scale system. You either have it or you don't. And it's a rather simplistic approach, but unfortunately, 90% of the eye doctors use this scale and this alone for all of their work. So their day in, day out routine is using a graded scale system where they're basically looking for pathology or some kind of visual impairment, and they're not looking at visual function. To look at visual function, we sometimes have to borrow our methodology from psychologists and neuropsychologists, and that is using a norm reference test, looking at eye movements compared to the norms, and looking at focusing compared to the norms, and looking at eye tracking compared to the norms, things of that nature, which is your bell-shaped curve, basically. And these are all tests that are beyond the basic vision examination. It was primarily developed during for children who had developmental disorders. So norm-based reference tests were developed to check eye tracking compared to children who had developmental problems in eye tracking that might be affecting their reading, or patients who are children who are in special needs services. And so they started looking at these norm reference tests more and the visual dysfunctions among the developmental learning problems. And one study found that children with IEPs, 69% had passed their visual screenings, meaning they could see good 20/20 vision or 20/30 vision, but yet had undiagnosed and untreated vision problems that were affecting reading speed and comprehension. And as a result, they were realizing that there was a lot of allocation of money toward IEPs without thoroughly investigating the visual system. They were just doing the minimal amount of screening with these kids. And lo and behold, they had such high numbers of tracking problems and focusing problems and eye teaming problems that were undiagnosed because they could read the 20/20 chart, that they started investing more and more time. And over the years, I would say it's been in my clinical experience at least 30 years, that this is becoming more and more a commonplace that children with IEPs are, instead of just giving a vision screening, we are looking and use norm reference tests to help uncover undiagnosed reading tests. Well, now we're seeing the same thing happen with head injury and acquired problems, vision problems, that we're looking at head injury more in depth, and it's being aided by a lot of these new technologies, eye tracking technologies. So going up that pyramid that we saw a little while ago, we're going up to the next level, the oculomotor based problems. What are the things we're interested in? Well, saccades and pursuits, which are the versional eye movements or eye movements in the same direction, vergences, which are movements in the opposite direction, and focusing. And these are three instruments that we use. One is called the RightEye, which is a remote eye tracker on the bottom left-hand corner. Basically, it displays targets on the screen. You follow it with your eyes, and it gives you a recorded printout of the accuracy of your eye movements to different displays. The second level, the middle one, is called the Visagraph. The Visagraph is an instrument which is specific for reading. Basically, it's a norm reference test where we compare the eye movements, compare eye movements of a head injured individual to norm-based scores in grade school or high school up to age 18. And then the instrument on the right is an instrument, an open field autorefractor, which measures the response of your focusing mechanism. So based on these objective measures, these are some of the visual impairments that have been found in, this is a military population. Convergence insufficiency with head injury is real common, where your eyes cannot turn in. Saccadic impairment are the quick eye movements associated with reading, up to 30% problems with that. Pursuit are the following slow moving following eye movements, 60% there. Misalignments of the eye where they can get it single, but there's still a misalignment, can be very common, and both horizontally and vertically. And then the focusing dysfunction is probably the highest, is 65% compared to normal population. So the objective ability to objectively measure these things and compare them to norm referenced tests is helping to uncover these hidden problems. This is the RightEye printout, which is used, which we have used in the past, and we still use it with head injury. On the left side, you are seeing a printout of fixation maintenance, smooth eye tracking following a moving target in a circle, and slow eye movement and quick eye movements vertically and horizontally. So those are the three big categories that you're seeing. On the left is normal. On the right, you can actually see graphically that there's a difficulty in fixation maintenance. There's difficulty, this erratic, trying to follow a moving target that's going in a circle, or making erratic eye movements quickly or up and down, or even slowly up and down to moving targets. You can see the dramatic difference with head injured versus non-head injured. And there's a whole panoply of analytics that can be done with this instrument, and even displays them in green, which is normal, versus red, which is abnormal, in the bottom right-hand corner of this printout. So these are very, very useful tools to help uncover hidden oculomotor dysfunctions. The Visagraph is the reading eye movement one, and you can see examples of good stair-step saccades and fixations for a good reader. As to a poor reader who maybe has a head injury, there's not this nice stair-step pattern to the eye movements. This is the printout that is given for the Visagraph. Again, it's norm reference, so we can compare a person's eye movements to different grade levels, and it'll give you a grade level performance. The performance on the right-hand side shows that this person has fixation eye movements around grade 2. They have regressive or backward eye movements at a grade 4. Their duration of fixation is longer than what would be expected for their average grade by 300ths of a millisecond. Reading rate is reduced. Grade level, instead of being at the 11th grade level, which would be their average, this person is functioning at eye movement behavior that labels them at 2.4 grade 2.4. So their eye movements are significantly diminished. And it doesn't, again, we don't know specifically if it's the eye movements that are creating the dysfunction in reading, or if there are other factors, but we can say that the eye movements during reading are not as efficient as what they should be for their age or grade level as a result of their head injury. And so this is probably, of all the tests that I use with patients who have head injury, I love this test because it gives me some goals. It gives me some idea of what their eye movement behaviors are like, and it can explain a lot with a person who is experiencing reading problems after a head injury. It can explain a lot. Any questions so far or thoughts on any of this? I'll keep going here. This is the open field autorefractor. Again, we're still on the second level of oculomotor dysfunction analysis. And this is a cool instrument because what it's doing is it's shining a beam of infrared light into this person who's sitting behind this window here. It's shining a little beam of light in there, and it's measuring the response of the focusing mechanism objectively. The response on the top, if you look on the right side, you'll see this response of somebody looking near and then far and then near and then far. And it's giving you a readout every few seconds, like 7 seconds, they're looking near and then far. And it's pretty accurate. The person below has an abnormal focusing response. You can see that it doesn't look as accurate when they're looking near to far. And that's very, very common after a head injury. The person says, probably generally will say, yeah, things are blurry. I have to really concentrate to get things cleared up for me. And so there's that relationship between attention and focusing, which is really, really common. And I'm fond of saying that you really can't separate attention from focusing. They're kind of hardwired. But this is a nice instrument to have to uncover that strong relationship between focusing and attention. There are two common tests, actually one common test that is done to determine if a person has an eye teaming or avergence dysfunction at near, called convergence insufficiency, is the doctor will usually, or a clinician will usually take a pen and bring it in slowly like this and watch the eyes converge. And most of us who have no head injury or no previous diagnosed problem should be able to keep that pen tip clear, or at least single, to 6 centimeters. It may be blurry, but they can keep it single to 6 centimeters. Anything beyond 6 centimeters is significant for a head injury. So that's a common test. But one of the things that we've done some research with is something called a receded near point of fixation disparity. A fixation disparity is something that happens before things go double. Let's say you're bringing a pen in and it goes double at 6 centimeters. Well, before that happens, something else happens. And that is, there's a little sliding of the retinas. The two eyes will slide apart just ever so slightly. It's not enough to make things go double, but the right eye and left eye are not in complete alignment. And by using this Polaroid target, where the right eye sees the top arrow and the left eye sees the bottom arrow, if those arrows misalign anywhere before 6 centimeters, there can be a high correlation with head injury. And so this is a test that we've been using to pick up subtle convergence problems. They may not be to the point of seeing double, but the patient is struggling to keep things lined up. And this can impair reading and any kind of close work. So it's a kind of a new test, and we really enjoy working with that. Now, after we've talked a little bit about some of what I call the efferent system or the oculomotor system, now we're going to talk a little bit about the non-oculomotor or afferent problems that occur. And most of them occur in what is called ambient processing, which has to do with our peripheral vision or our side vision predominantly, rather than our focal, straight ahead, small, detail-oriented vision, okay? And there are several things that can happen as a result of a head injury to our ambient processing. One is, I think I mentioned, is that we can have an abnormal egocentric spatial localization. Basically, we have an altered sense of what's straight ahead. And sometimes to help this, we use yoked prisms, or prisms that are in the same direction to shift space. So when we wear these prisms, our spatial world seems to be shifted to the left. We can shift it to the right, up or down, depending on where there's an abnormal egocentric spatial localization. And that's important to have, is a good normal egocentric spatial localization, so that we don't encounter balance problems or posture problems. The second area that we often find to be disrupted is our photosensitivity, a hypersensitivity to light. It can be indoor light, it can be computer light, it can be our overhead fluorescent light, or it could be outdoor light, but it's almost ubiquitous with a head injury that there is some sort of photosensitivity, and that can be helped with tints or wide brimmed hats outside. Motion sensitivity, very, very common, where we'll hear from patients they don't feel safe driving, moving things around the car when they're driving, or if they're in the passenger seat, make them nauseous. Going to a grocery store and just walking down an aisle, for instance, might create motion sensitivity. And to help patients handle this, we use either binasal occlusion, sometimes tints, and sometimes we have to desensitize their brain to this motion sensitivity problem. We're all kind of familiar with the vestibular dysfunction because of the vestibular system and the visual system are connected. And sometimes it can be isolated vestibular problem, but sometimes there can be a vision problem that is exacerbating the vestibular problem. So we have some therapies that can maybe help in vestibular rehabilitation. Visual field defect, we talked about the impairment, but there can be what's called a visual field neglect, where there's a spatial inattention to one side or the other side of one's visual field. And usually it's the left visual field that a person may have trouble attending to because of spatial inattention. And usually that can be helped with therapy. And again, finally, just visual information processing, figure ground discrimination, visual memory improvement can be achieved through perceptual therapy. So things of that nature. And that's that third level. We think that these two levels that we just talked about, and there are more and more tests that are being used to isolate and understand how these work. We think this is important to better understand how our attention and our cognition are involved with vision-related problems of head injury. This is a nice slide because it kind of expresses what we know to be different in our brain's function between focal vision and ambient vision. Typically, our focal vision is what most doctors think about when, and most of us think about when we go to an eye exam, our focal vision. How clear is it? And it's usually assessed using non-moving targets on a chart 20 feet away. That's black on white, and it's small. But our ambient vision is somewhat different. It responds to motion. It responds to low contrast, not high contrast. And it responds to things that are large. And there's actually two networks in our brain that start separating these two visual processes and then reintegrates them so that we make sense of what we see in our world. So those are the two systems. And this is kind of a nice little slide to help differentiate our focal vision from our ambient vision. Well, how do we measure the ambient vision? Like I said, we're more aware of how to test for focal attention, but how do we measure our ambient vision? Well, one of the things that we've been using, and we like this because we've done some research with us, and it seems to be very sensitive to teasing out what is ambient versus what is focal, and it's called VEP, visual evoked potential. And basically, visual evoked potential are the responses of our visual cortex, which is in the back of our brain, to different stimuli in front of us. And if we take the stimuli and we separate the two stimuli. In other words, stimulate the visual system using small, high contrast information that's moving rather slowly. And then we compare it to information processing in our visual cortex that's larger, low contrast, very fast moving. We will see a difference usually after a head injury in the speed of the response or the latency of the response to our visual cortex to these two stimuli. And usually what we have found is that after a head injury, there tends to be a delay in the information that is processed through our ambient system. And then we can measure this in milliseconds, that there is a delay in or lag in that ambient processing. And so instead of information coming into our visual system through the focal and ambient systems at the same time, what tends to happen after a head injury is information is starting to come in delayed in one of our systems. And we think that might explain why patients have this persistent motion sensitivity and hypersensitivity to light, that there's this delay problem. And it's kind of like when you watch a movie and the sound from the movie or the synchrony of the lips moving, let's say somebody's speaking on a movie and there's a dyssynchrony between the lips moving and the voice coming out. Well, it can happen just with our visual system, that the center part of our vision is not coming to our brain at the same time our side vision's coming in. And this dyssynchrony between our side and our center vision is thought to be a major cause of disruption and disorientation after a head injury as well. What are some other ways we can start measuring these problems? Well, here's just an example, by the way. This is an example of the timing difference. We all have a little bit of a timing difference between our center and our side vision. And because of that little bit of timing difference, you will notice that as you scan this slide, that it seems like these wheels are kind of rotating on you. Okay, it's kind of a weird percept. Well, when a person has a head injury, it's really exaggerated. It's almost intolerable for a patient with a head injury to even look at this because of the extreme motion sensitivity that they will experience. So this is just kind of a nice little example of the difference between focal and peripheral or ambient processing. But as I said before, there's a lot of patients who just going down the supermarket aisle, there's a difference in the speed of processing between your side vision and your center vision. And this difference in speed causes symptoms like visual vertigo. Another way we have used to measure this ambient processing is using what's called coherent motion thresholds. Basically, what you're seeing here is a computer screen that has 300 pixels moving, 150 on each side of the screen. And what this test does is it has random moving, imagine these pixels on either side of the screen are moving randomly in all kinds of different directions. Well, what the computer does is it can generate a group of them on one side or the other, not all of them, but a group of them that will move together for about 3 seconds. And the observer has to look at the screen and try to figure out which side has the group moving together. And what the computer does is it makes fewer and fewer and fewer of the moving pixels move together as a group. And what we have found is patients with a head injury will have to see many more moving as a group compared to a person without a head injury. In other words, they have trouble separating the movement, the coherent motion, from the random noise. The random noise is so overwhelming that you have to get a huge group moving together to be able to see it. And so that's one characteristic of this ambient processing dysfunction. Or another test that is used is called the critical flicker frequency threshold test. basically it's a device that you see in front of you. It's a light that flickers in front of you. And what the observer sees is a flicker that goes faster and faster and faster and faster until it becomes a steady beam. When it becomes a steady beam, there's a little button on the back, and they push the button or release the button when the light that is flickering becomes a steady stream of light, no more flicker. And then it does just the opposite. It starts as a steady stream, and then it becomes a gradually slower and slower steady stream until it starts flickering, and the person releases a button when it starts flickering. And what we've found that patients who have a hypersensitivity to light, let's say, or photosensitivity, they see flicker when other people don't. So it's kind of an interesting thing. And again, there are tests of egocentric. This is just a test where we can determine if a person has the center where they think their center of visual world is. It coincides with their egocentric spatial localization, or if it's shifted, skewed to one side or another. Now we're getting into some more interesting research that we have been doing. Dr. Poltowski over at the University of North Dakota, we published this in Nature or Scientific Reports a year ago, last November. And this was an interesting study. We had 81 young athletes who were wired up to EEG while they performed some visual motor activities. And 18 of this group of 81 young athletes had a history of concussion, yet they had no symptoms. And we were measuring their EEG to some activities. And what we discovered was that there was an abnormal allocation of attention to the group of athletes who had a history of concussion, meaning they had to use frontal lobe activity while others were more automated in did not have to use as much frontal lobe activity to perform the task. So what it says to us is that even after a concussion and even after a person is recovered with quote unquote and are back to normal, they may not be back to normal, that they may have to use different attention allocation than patients who have never had a concussion. And so this is we publish, and we think, again, this is just attention may be altered after a head injury, even months or years later. And of course, what do we do with all these problems of oculomotor and non-oculomotor dysfunction? Well, there's something called neuro-optometric vision rehabilitation, where we look at we take those oculomotor skills and we train each of them separately. We try to desensitize the motion sensitivity and light sensitivity, and we try to integrate these with balance and motor activities so that the oculomotor skill can be automated, so that we don't have to use our cognitive resources and deplete our cognitive resources just to get our eyes to do what we want them to do, to get them to aim right, or get them to track well, or get them to focus. If we can reduce that tendency to have to allocate our attentional resources to something that's relatively fundamental, or used to be fundamental before our head injury, that's the goal. And once we do that, it seems that we can free up our cognitive and our attentional energies to other tasks rather than diverting them to the visual processing, if that makes sense. And again, this is just a description of what neuro-optometric vision rehabilitation is, who does it. And these are the components behind. Just like any therapy, you need motivation, feedback, repetition, creating a mismatch of the sensory and the motor, and integrating them together is what vision rehabilitation is all about. Finally, once we have that visual system, the oculomotor and non-oculomotor systems normalized as best as possible, then we feel it's appropriate to make sure these other issues, these non-vision-based problems are addressed. Things that may persist like depression, fatigue, maybe there's some nutritional issues that are going on. Maybe they do need targeted cognitive therapy, or there's some other behavioral problems that need addressed, or medications that need modifying. Maybe there's some residual problems with posture, and the appropriate practitioner should be involved with that. And again, there may still be some attentional issues that are not completely resolved from our previous therapy, and they need to be addressed as well. So that's basically it. And if I had one other tool, I mentioned the Visagraph being one wonderful tool, but let's say I wasn't an optometrist, I didn't have that tool. Is there another tool that's in that toolbox that we can use to help identify the vision problems with head injury? This is it. This is called the Brain Injury Vision Symptom Survey. It's a 28-item self-administered test. Covers 7 areas of eyesight clarity, visual comfort, diplopia or double vision, depth perception, dry eye, light sensitivity, and reading. Those are the 7 areas that, and there's a link below, you can get a copy of it and use it in your clinic, or if you work with anybody with a head injury, this is a wonderful one to use so that you know how and when to refer. That's it, folks. So I'm open to any questions that you might have.
Great information.
Doctor, I've got a question back there in that one slide where you showed, well, the one I remember is counseling with medications. What if you've been able to, I've been able to quit my medications for about a couple of years now, but I occasionally do need counseling. Do we need medications for these injuries we've had?
I think it's kind of one of those things, Skip, where you almost need all the different disciplines and all the different interdisciplinary work to try to solve it. Some patients respond well to one therapy, and yet we find that for some reason this person is really resistant, or let's say their brain is really hypersensitive. Boy, we're going to need maybe this other profession's help, like with medication, to try to reduce the symptoms that they're having. So I think that's what one of the things that I've learned working with the head injury is, if you've seen one head injury, you've seen one head injury. Everybody's so different.
Okay, my vision problem. See, when I fell about I'm not sure, but over 2 years ago, I hit my head right here on the edge of an oak thing.
Oh.
And I've had some physical therapy, and where you talked about that vision thing, this therapist showed me how to do that.
Yes.
And like the vision problems I'm having now, my unbalancing now could possibly be the after effects of this injury, this fall I had here.
It could be. Yeah, we just don't know. We think we're learning more and more, Skip, about how these things interact, and it could be visual, it may be vestibular that you're experiencing. We don't know exactly.
Okay. That one you showed with those wheels and all the green wheel, like,
that's
man,
strange. Some people, like I said, with a head injury, they look at that and they go, "Oh, get this out of my face." Yeah.
Yeah. Okay. Thank you.
You could use that as a screening tool if you wanted to find out if a person's had a concussion. Just pull that up, and
Sure.
if they jump back, then they probably had a concussion.
We have another question here. Is there a specific referral needed in order to begin vision therapy?
No, no. There isn't. Doesn't have to go through a physiatrist or any primary care. Anybody who is, especially if you have a screener that, like I showed,
Like the bit
is a checklist. That's all you really need.
Okay, great. Who else has questions? think we're one of our record attendance for
Oh, very good.
Wednesday. Popular, Dr. Biberdorf.
No, it's vacation
32
time.
people on.
I found this really interesting and pretty helpful
Yeah, thank you.
information.
Yeah,
It is. And you know, when you were talking about I had to put my special ed hat on for a minute. When you talked about that page with like IEPs and how there's so many kids missed. So what should teachers be looking for if they're passing their regular vision test? I mean, how would we even really know to do a referral to you or to?
well, it kind of works hand in hand. You look at symptoms, and there are more better checklists, let's put it that way, for symptoms of but my issue, I guess I look at reading problems. Anybody with a reading problem doesn't need a screener, because that's not going to pick it up. Anybody with a reading problem need to have a normative based assessment at breaking down that visual system. What does focusing look like? What does eye teaming look like? What does tracking look like? And should have that in a report. Otherwise, you really don't know. And one of the interesting things, the person who had done the latest literature study on that found that many of these kids need what's called a cycloplegic exam. They need eye drops in their eyes to paralyze their focusing in order to uncover hidden farsightedness, because many of these kids were passing a farsighted screening without these eye drops. And then they were putting these eye drops in there going, where did all this farsightedness come from? We didn't think that kid had it. And just by providing some relaxing glasses, just simple relaxing glasses so they don't have to work so hard, made a huge difference. And that goes back to this attention issue.
Okay.
We had done a study, for instance, where we artificially made people farsighted. This was a university study we did. We took university students and we put them on by a laptop, and we made them wear -2 lenses. -2 lenses isn't terrible. You can still see 20/20, but it does put enough stress on the system that we were able to create people with attention deficit disorder. And they had no attention deficit disorder, but we also wired them to EEG, and we said, look at what just a little bit of excessive energy does for the visual system working a little harder than it has to. Look what it does to our attention mechanism. It kind of wrecks it. And so we often think kids who have ADHD, we want to make sure, for instance, that they don't have a vision problem, or maybe just excessive farsightedness. Get that ruled out. And the exact same thing goes with our head injured. Our head injured, we tend to just kind of, they got a cognitive problem, or they have a visual memory problem. Let's work on that. Well, maybe just take a step back and say, let's get that visual system analyzed first, because we may be spending a lot of resources and energy pursuing something that really could be easily solved. And hey, it's maybe a different pair of glasses just for the computer, that kind of thing.
Sure. Nice. Good. All right, Karen has a question. Is the brain damage of a child that incurred due to prenatal meth exposure the same as a TBI? Meaning these same ideas and research apply?
I think it really applies. In fact, I was working out one day with an anesthesiologist over at Alter, and I said, you know what we should do is we should really look at children who have had major surgeries where there may have been prolonged use of anesthesia. They've been under anesthesia, and let's look at their issues afterwards, because I have a strong feeling that there is a correlation with their subsequent learning problems and maybe some vision issues that haven't been uncovered. So it's an interesting thing that I think somebody needs to look at.
Yep. Good.
Well, I hope everybody has a good rest of the holiday and stays COVID free. And
yes.
And oh my gosh, I can't believe educators. I don't know how they can do it. Yeah.
Yes. They need to be paid much more.
Yeah, that's exactly it. They didn't go to school to be IT people and everything else. It's
All
amazing.
right.
Yeah.
Right. Okay. Oh, someone asked any noted symptoms with COVID as far as vision.
Interesting you brought that up. I think we talked about that briefly, is that I think we're going to find it. I think we're going to find increased incidence of eye diseases like glaucoma because of some of these. I think there's going to be some neurological issues. They're talking about these mini strokes that these people are having, or these silent strokes. I think we're going to see some major issues there. You know, anecdotally, we have found patients who say, I'm still in a fog. I'm still in this funk and fog. And I think the research is really going to bear out that patients who have gone through COVID may have some residual problems because of the neurology involved. So, yeah.
Sure.
So what are your suggestions or ideas about continuing with follow-up on this, since you've had COVID and then and other illnesses that followed after COVID, like pneumonia?
I think you're right, Skip. I think we need to follow up on them and start analyzing these things. I think we're going to discover these things are going to be high on the list, and it's just a matter of not time. You know, all of our effort now is keeping people alive, but down the road it's going to be, okay, now that we know they survived it, okay, now what are we going to find? Yeah.
So like a year from, well, let's say the COVID was last month you had, and like a year from now, it'd be good to do a follow-up, follow-up.
Yeah, I still think it's interesting. And if there is a doctor, we were just talking with Carly, there's a doctor who does hyperbaric oxygen treatments in Fargo, and that's what she's doing right now, is taking these patients who are maybe several months out from having COVID, but they still cannot get their brain together. They just cannot get things working well. So she's putting them through hyperbaric oxygen to see if she can help them recuperate some of their cognitive processes that are sluggish, or some other areas. So I think it's going to be an interesting thing to see how she does. Yeah.
Can you explain that oxygen thing you were mentioning?
Hyperbaric oxygen is a treatment where they put your entire body in a 100% oxygen under higher pressure. And supposedly what happens, instead of your hemoglobin being the only entity in your blood that picks up oxygen and delivers it to tissue, the blood plasma itself is so hyper rich with oxygen that it too can feed normal cells outside the hemoglobin. It'll feed these cells with extraordinary amounts of oxygen. So if there's been a part of your brain, let's say, that has been deprived of oxygen for a long period of time, or even a short period of time, maybe immersing it in a hyperbaric oxygen environment may enable those tissues to recover faster. That's the theory behind it. Any kind of inflammation in your body, for instance, a strained or broken or strained knee, let's say, or any kind of inflammation, this seems to be helpful for.
Thank you.
Mm-hmm. Well, this is great.
Yes, thank you so much for your time today. Appreciate it.
Mask, Sandy. Take care, everybody.
Okay, sounds
I'm gonna
good.
send you, Carly, I'll send you a copy of everything.
Thank you so much. Appreciate it.
If anybody,
Happy holidays,
Thank you.
everybody. Happy New Year, everybody.
yes, okay.
Thank you.
Yep. Bye-bye.
Thank
Bye.
you. Bye.
Thank you.